First of all, I request the chairpersons for this session, Dr. J. Srinivas sir and Dr. Rajesh K. Who's consultant at Apollo Hospitals, Vishakhapatnam. J. Srinivas sir, all of us know him, to chair this session.
Thank you, madam. And now I request Dr. Yatin Mehta sir to give a talk on albumin, resuscitation fluid of choice. And sir is chairman Medanta Institute of Critical Care and Anesthesiology, the Medanta Medicity Hospitals, Gurgaon. Sir, over to you, sir.
Thank you. Pleasure to be here. Really enjoyed my stay at Vizag, one of the, I think, most beautiful cities in the country. So I must thank the organizers, particularly Dr. Mohan, to invite me here, which has been pending for a long time, so finally I think I managed to come. So I'm going to talk about use of albumin in resuscitation. I bring you greetings from Medanta, the Medicity, where I work, outskirts of New Delhi. This is what the molecule looks like. So it's the most important protein in the serum, and it constitutes about 75% of the oncotic pressure of the plasma is because of this. It is easily exchanged between the interstitium and the intravascular, about 5% per hour, about 3.5 to 5 is the normal level. So as I said, 2/3 is because of the oncotic pressure, 1/3 is because of a chemical structure. And it does prevent, in guinea pig heart, it has been shown to prevent extravasation into the extravascular lung water. So there are two, primarily one poorly recognized thing is it is a very major antioxidant and anti-inflammatory molecule because of primarily sulfhydryl group, and it also binds the metal ions. It stabilizes, now the glycocalyx is becoming very fashionable. It is very important, and endothelialitis has come in COVID-19, it has become an important part of the etiology discussion. So it stabilizes the endothelium. It also has anti-inflammatory, anti-thrombotic effects, and it binds to nitric oxide. So again, anti-inflammatory and anti-thrombotic effects do become important in the present times. So let's review the literature, then we'll come to some sort of conclusion. It can be a little confusing. So the earlier studies, 1998, there's a meta-analysis, 24 trials, 1,500 patients, albumin compared to normal saline in hypovolemia. They found 6% increase mortality in albumin. 2001, again meta-analysis of 55 trials, 3,500 patients, no significant difference in mortality. 2002, Martin et al., again this is a randomized controlled trial, improved mortality with albumin, that means decreased mortality, improved oxygenation, particularly in hypoproteinemic patients. So it does make sense, particularly if the serum albumin levels are low, not to load them with too much of crystalloids. Now this was a famous SAFE study, roughly 7,000 patients, 2004. So they found 4% albumin was safe compared to normal saline. TBI is not to be used, detrimental effect, but in patients with septic shock, it had a beneficial effect. So in 1,200 patients out of this in post hoc analysis, decreased risk of death at 28 days compared to normal saline. And ARDS patients, you had a good discussion on ARDS in the previous talk, beneficial to give albumin. Okay, Anderson's 2004, can be safely used in critical ill patients. Martin 2005, hypoproteinemia again, oxygenation improves, hemodynamic stability improves. And Alderson, no evidence of survival benefit. Albumin versus as a resuscitation fluid, meta-analysis again, 2011, more recent one, 17 studies, 2,000 roughly patients. Only 8 studies were only with sepsis, patients with sepsis. Conclusion was use of albumin for resuscitation of patients with sepsis was associated with a reduction in mortality, odds ratio of 0.8. So that is a positive finding of the meta-analysis. There were several criticisms of these studies, which I have talked about. Primarily, safe study was not to differentiate between albumin and saline, and not all patients were included in the multivariate analysis. Delaney study, a meta-analysis, there were no predefined subgroups who were enrolled in the 19 trials for a mortality benefit. Now, this was in RCT 2014, NEJM published, albumin in patients with severe sepsis and septic shock. Italian study, 20% albumin plus crystalloid versus crystalloid alone. Multi-center, open label, 1,818 patients with severe sepsis. So higher mean arterial pressure was achieved with albumin, significantly higher mean arterial pressure. Shorter time to reach the mean arterial pressure, that means within 6 hours. Shorter time for discontinuation of vasopressors. Did not improve 28-day and 90-day survival, and no significant difference in the other secondary outcomes. But this is a significant finding. Mean arterial pressure was better preserved, faster achieved of 65, and vasopressor withdrawal was also faster. So, too much of fluid, does it help you? I suppose some of you may recognize this slide. Okay. Now, there are several studies. If you look at this association between fluid overload and detrimental of lung function or increase in mortality. Previous speaker has discussed it quite in detail, and these are the studies. Virtually all the studies have shown increased mortality in patients who have are administered excessive fluid. Ventilator-free days are less, mortality is higher, gut motility is reduced, encephalopathy is higher. So, I mean, by and large, too much of fluid. Now, how much of too much of fluid is? I'll come to that in the next few slides. So, what do you see here? You see commonly pedal edema, encephalopathy, myocardial dysfunction, diastolic dysfunction of the heart, gut motility is reduced, enteral feeding is delayed, malabsorption happens, kidney function also surprisingly is worse in patients long-term in patients who are given excessive fluid overload. So it is mostly, by and large, not really recommended. So you have to strike a balance between your colloids and crystalloid. Normal saline, obviously, if you're giving crystalloids, you will not nowadays use too much of normal saline because of too much of chloride and acidosis. So let's look at some more papers. 12,500 patients, albumin versus crystalloid in fluid resuscitation. 30-day, well, there was no significant really difference. 90-day mortality, no significant difference. NEAT or RRT also no significant difference between the two, but at least not worse than the previous one. Again, in this study, ringer lactate versus 4% albumin and ringer lactate. Single center, randomized double-blind study, 360 patients of cancer. Bolus of albumin in a ringer lactate versus ringer lactate alone in first 6 hours. No improvement in 7-day survival. If some of you may have heard Jean-Louis Vassa saying, this was not surprising. In 6 hours' time, if something is used extra, too much or whatever, unlikely to show long-term mortality benefit. Bassett's paper again, 55 RCTs, 27,000 patients. Mean arterial pressure was significantly lower in crystalloids. So this just re-emphasizes that mean arterial pressure is achieved higher and better with albumin or with whatever you're using. More fluids were administered in patients who were not given albumin. Crystalloid people received a higher this thing, and cardiac index also was better in albumin group compared to the crystalloid group. Now, recently you've seen the surviving sepsis guidelines for sepsis and septic shock, just been published. So let us see. This is me. We're lucky enough to represent ISCCM. Okay, so what do they say in the surviving sepsis guideline? For adults with sepsis or septic shock, we suggest using albumin in patients who received large volumes of crystalloids. Evidence shows that earlier achievement of higher blood pressure, that means mean arterial pressure, and lower net fluid balance in patients who were given albumin. Higher static filling pressures, They measured CVP primarily in patients who received albumin. Limited data precludes a cutoff value. At what value, I have discussed this earlier, that what value you say it is too much. But there is one study at less than 5 liters was considered low fluid resuscitation, and higher than 5 to 9 was considered higher fluid resuscitation. So again, coming to other types of colloids like gelatin and starches, for adults with sepsis or septic shock, we recommend against using both starches as well as gelatin. So this is the recommendation. At the moment in septic shock, gelatins and starches are not to be used, and albumin may be used if your crystalloids are excessive. So as I said, how much is more? This Paul Merrick's paper again, high volume resuscitation. So 5 liters was the cutoff value, as said. But debate continues, whatever the reason may be. So again, 2020, a recent paper, normal saline versus albumin and normal saline. It is a retrospective study. The conclusion, you can say, during large volume resuscitation, 5% albumin was associated with reduced mortality and major adverse kidney events. This is John Callum's group. He does a lot of, he's primarily a nephrologist, a lot of work on that. So major adverse kidney events were much lower in albumin group, although AKI not requiring RRT was higher, but there was mortality benefit. So this is a significant benefit of mortality in this group of patients. Coming to 20% versus 4% albumin, in India we have 5%. Excuse me. So randomized clinical SWIPE study, 321 patients. Cumulative volume of resuscitation at 48 hours was lower with 20% albumin. That is understandable compared to the 5% group. Total fluid requirement was less in the 20% group. There was a more positive fluid balance in the 5% group. So obviously, positive fluid balance after, I think, 72 hours is associated with mortality. So concluding what I have been talking about, the surviving sepsis guidelines summarizes it all. For adults with sepsis or septic shock, we suggest using albumin in patients who receive large volume of crystalloids. Use of albumin during resuscitation is associated with decreased net fluid balance. Albumin is likely to benefit during resuscitation of septic shock patients receiving large volume of crystalloid, and one study has shown is more than 5 liters. Trigger volume of resuscitation is yet to be ascertained definitively. One study suggests more than 5 liters. Further research is required. So thank you very much for your attention.
Thank you, sir. Any questions? From 1 or 2 questions? Yeah.
As the cutoff, there is no hard and fast. It was 5 to 9 liters. But yes, if you're using liters of fluid, most of the acute resuscitation in septic shock is about 30 ml per kilo. Most of the major studies have shown 30 ml per kilo. So if you're, I would think if you're exceeding more than 2 and 3 liters, it's a good idea to add some albumin. If you are giving albumin to correct hypoproteinemia, particularly in patient with ascites or is losing protein somewhere, then I think 20% albumin makes more sense. 5% albumin has very limited really benefit. And starches and gelatin are out in septic shock. That's a good question, but I don't know. I cannot explain it. Although the major adverse kidney events were less in the albumin group. But AKI was not requiring RRT. So they went by the strict definition, definition. I'm sorry? See, I don't know how much albumin level in the serum will reflect the total albumin in the body. But if the patient is hypoalbuminemic and hypotensive, there is no question. I think it does make sense to use albumin. Clinically, I'm saying. I'm not based everything on evidence. Yes, so albumin is normal and the patient is not too much of fluid positive, then I will see what's to be done. But if you're requiring too much of fluid, yes. If the patient has cardiac dysfunction, yes. Then I would use albumin earlier.
Thank you, sir. And Thank you, sir.